Αρχίσουμε τώρα και έχουμε αρκετό χρόνο για κάτι πάρα πολύ ενδιαφέρον και χρήσιμο και χαίρομαι ότι βρίσκεται εδώ πέρα και ο Γιώργος ο Χαρώνης, ο οποίος εύχομαι από τη νέα θέση την οποία θα έχει τον επόμενο χρόνο να μπορέσει να βάλει το στίγμα του προκειμένου κάποια πράγματα να γίνουν πραγματικότητα. Τι είναι αυτό? Remote Access Simulated Surgery for Young Ophthalmologists in Post-COVID Era. Έχουμε δύο εξαίρετους συναδέλφους. Ο Γιάννης Αζανίδης βοήθησε προκειμένου να έρθουν εδώ. Είναι ο Χάτς Μάκεντζι και ο Μάγιανακ Ναναπάτη. Έχουν έρθει από το Ηνωμένο Βασίλειο και θα μας μιλήσουν για όλο αυτό το οποίο είναι Simulated Surgery. Please.
Oh, it's okay anyway, isn't it?
That's it. Please. Have a seat over there.
Thank you. It's a real pleasure to be here, and thank you to Professor Datseris and Professor Aslanides for inviting myself and Professor Nanavati. I'm going to talk a little bit about training in the post-COVID era, what we've been doing in our unit, and I represent a surgical training centre, the Iceni Centre in Colchester, and we'll talk a little bit about what does the future hold for surgical training, and can we kind of generate a cooperative approach to this between countries and spaces. So this is what we currently do, wet lab training. This is a kind of typical wet lab that we run in our centre. This was for DSEC or keratoplasty. Of course, you can see that this is, everybody could catch COVID off each other in 10 minutes. If this was in the COVID era, we wouldn't be allowed to run this now as it stands. In our operating, we also use 3D visualization tools like the Ingenuity to allow trainee surgeons to share their experiences, and it allows us to supervise better. But COVID really was a time for change for us, with restrictions on traveling, restrictions on groups, transplant tissue, difficult availability of training, and it's encouraged us to look at remote training. So this is a kind of typical remote training setup that we use. You can see that there's a sort of laptop and hooked up to a webcam, and basically this is linked to a microscope. So if you have access to a sort of standard surgical setup, the cost requirements is very minimal. So you can use your existing surgical microscope or a wet lab setup like the one you see on the table in front of us. You need to connect that to any laptop really, and a webcam, the one built into the laptop, is okay. And we carried out a kind of simulation session, as if that wasn't enough of a mouthful. And you can see Mr. Nanavati training at home in his, that's not your pajamas, Mike, is it? No. But something equally comfortable on the sofa. And I was the kind of local trainer in Colchester. This is my trainee, Dr. Yang, who's being assisted in training by Mr. Nanavati, who's sort of going through that procedure. And you can simulate quite a lot of these with the plastic eyes now. You can see what the trainee's hands are doing live on camera, and both of us can offer advice to the trainee in terms of the procedure, and various phases of cataract surgery can be simulated like this, and trainees really benefit from this sort of training. So what do I see that the future holds? Well, I think between Greece and the UK, we share a lot of education. Many Greek ophthalmologists were trained in the UK, and many UK ophthalmologists like me did part of our training in Greece. So I think that there are already a lot of connections in what we do and how we do it. I think that this COVID era is an ideal opportunity to strengthen those links and to look at ways that we can use remote surgical training to offer trainees on both sides of the oceans the best that our trainers can offer. And I think afterwards we'd be very happy if there are any individuals or institutions that would be interested in working with us to deliver surgical training curriculum. I'd be very happy to take that discussion. Thank you very much.
Thank you, Raj. I'm just going to switch over to my presentation. Thank you very much, Yanis and OMA Group, to invite me for the presentation, and Hatch. Thank you, Hatch, for working on this project with me. My talk is about what would you do if you don't have a proper setup in your place? Can you still train your trainees? The answer is yes. These are my non-related financial disclosures. So we have published a couple of papers on that, and I'm going to show you the gist of the papers rather than actually going through the scientific material of the papers. This is the first scenario. What would you do when you have got an operating theater, but you don't have the patients to train on? And this is what you do. So this is a video made by my trainee. Essentially, for the different steps of the cataract surgery, you will simulate the cataract surgery on things which are easily available. So you can operate through the microscope. You can take a grape, for example, to do the incisions, and we are going to go through each and every step in detail. So for the incisions, for example, we can use grapes. You can have a grape on a spoon, slice the grape in the middle, put 2 marks with a sketch pen or a skin marking pen, and then you can use a keratome to do incisions. This can mimic your real cataract surgery incision, like so. And somebody has to watch you do that and to guide you through that. And you can do the side incisions in a similar way as well. So the next step would be to do the Capsulorhexis, which often is found difficult. So we devised a technique where we are using a lozenge, a cuff lozenge packet, remove the tablet from the lozenge, and then you can make a slit on the plastic and use the aluminum foil as your capsule. And then you can create a nick with any sharp instruments and then use a forceps of any kind to do the rhexis. The lozenge plastic cover will act as a cornea for you, and then you've got a stab incision in the corneal on the side to do your rhexis from the side. And this way you can use so many lozenge packages to do the rhexis under your microscope in the theater. You can even ask your trainees to stay back in the evening and do this in their leisure and record some videos for you to look at. Hydrodissection, similar to what we do in the cataract surgery. You can again use the grape model. So create a small little circular opening in the grape and use a Rycroft hydrodissection cannula, and you can do that very easily. The aim here is to ask the trainee, make sure that the grape doesn't rock or doesn't move while you're doing the hydrodissection, because if that happens, then the hydrodissection is too aggressive. The next step would be the second instrument, which is often a problem for trainees because it's a left hand they're using. And the best thing is to see how they can manipulate that. And in the second video, I'll show you what can be done for the dexterity of the left hand as well. So they can punch the lozenge and use the chopper or other things. Now for the sculpting, we have used cheese block in a lozenge package. So soft cheese, you cut it into a circle, remove the lozenge, and place a cheese block in it. And then take a syringe. This is just a simple 5 ml syringe. We didn't have 1 ml in the theater at that time, but you can use a simple syringe, which you can hold like a phaco probe, and the tip you can slice at 45 degrees if you want to. And with the tip, you can start eating the cheese as though you are doing a sculpting within the cataract, like so. And it works very nicely, as long as the cheese is soft and not hard. And then you can crack it as well. So for cracking, you need a pre-chopped cheese block. Any soft cheese, again, would work for that, and create a kind of decent cross with that before you place it into the lozenge package. And once you've done that, you can easily crack it with your syringe, which is acting as a phaco probe. So, as I said, use a smaller syringe if you can, not a bigger one, which I've shown you here in the video. And that way you can easily, and also you can size a cheese block as per the lozenge packet size. Here, there's slight discrepancy between the sizes. Aspiration of the material, the same thing, we use the lozenge package, but this time we replace the substance with the eatable jelly. You go to a supermarket, get some jelly, and you can then fill the lozenge packet with the jelly, like so. Essentially, these are the empty lozenge packages filled with jelly. And then you stab the plastic at two sides, like you do your bimanual irrigation aspiration, and you can irrigate and aspirate on both sides by swapping your hands. And this gives a decent feel for the trainee about the cortex. They won't get the real gist of a live case, but at least they will know how to move their hands in what direction and what to get hold of when doing so. Viscoelastic insertion and injection, again, you can slice a grape, create a small little groove in the center, and then do your incision towards the groove. You can fill that groove with viscoelastic, which is like filling a chamber, similar to a cataract surgery, as you see here. And then take any sponge, which is available as rubbish in your theater, load and inject a cartridge with the sponge, and inject the sponge through the incision. So this is just a rubbish sponge, which was there in the theater, which we used, and push it inside. This is an Alcon Monarch system for loading. Don't have any financial interest in this. And then you can use that sponge. The sponge has to be slightly harder, not too soft. And it's amazing that you can actually mimic the same kind of delivery feel with the sponge as well as the lens. And you'll see that in a second. And you can deliver the sponge into the grape groove through the incision you made. So hold the grape, which is like holding the eye, and then inject the sponge slowly, like so. And it does go in, and you get a feel like you are injecting a lens inside an eye, essentially. So that's what you can do with the microscope, if you have the microscope. Corneal hydration is very simple. You can hydrate the wounds on the grapes, so I'm not going to go through that part of it. We also published another technique on what if you don't have microscope set up and there's a pandemic lockdown. The surgeons and the trainees are both at home and they don't have any access to anything which I mentioned, apart from some instruments. So this is a scenario. This is your microscope then. You can use your modern iPhones and smartphones, which has got ability to enlarge and magnify stuff. You can use your books as your phone holders, and then underneath the phone you can have your lozenge packages and do the surgery. And you can also record it on your phones. So this is the first incision video, essentially showing you the same incision things as we mentioned earlier with the grape model. So I'm not going to go through this grape model incision again. And let's move on to the second slide here. So this is the Capsulorhexis part of it. And with the rhexis, what we tend to do is to take a boiled potato peel with some substance of potato attached to it. Then you make a small circular mark on the potato peel. You don't want the whole potato because you want this peel to stay on a cardboard. And then put an anterior chamber cover, which again here, we use lozenge packets too much in our experiment. You can cut a hole on the side of that for your main incision, and you're sticking that cover on the cardboard. So this forms your anterior chamber and the cornea. And now you can use a rhexis forceps and a cystotome in the exact same fashion as you would normally do in an eye. So you can lift the skin of the potato with a cystotome, as we show here, and then use a forceps. Now, these things work very well for the trainees who have never done a cataract surgery, and you'll be amazed at how good they become when they actually touch the eye for the first time, because it gives them the feel of things and holding things and moving the things around within the eyeball. The aim here for the trainee is not to touch any part of the inside of the plastic, so that they know the importance of the endothelium and they don't scratch the endothelium as they go along. And it's amazing that the potato peels actually feel similar to rhexis as well, actually, if you're doing that. So the next video is on the next step, which is the dexterity. So we are using the second instruments now through the sideboard. How would you ensure that the trainee has got enough dexterity between the two hands to use the left hand more proficiently? And to make them practice using their left hand, this is the techniques. You can ask them to cut straw, the drinking straw, into small little pieces, like to create these hoops, and use two incisions, like your bimanual incisions, through the plastic cap of the lozenge, and ask them to pass a thread through the hoops there, like showing you here in this video. And they will do this without touching the back or inside cover of the plastic lozenge cap. That way they will know the importance of small space, how to move their hands, especially how to move their left hand while they're using the phaco probe in the right hand, if they are right-handed person, and so forth. And ensure that they have all the loops in there. And that way, if they practice this, the left hand becomes very free at the time of surgery. And it's important to teach that as well. I'm just going to fast forward that to the next video, which is, again, dexterity using dots. Now, in this video, we're using cereal balls, like Cocoa Pops or Cocoa Balls, like so. You make a cross and ask the trainee to hold each ball and put it in a fixed place. So here we said, why don't you hold each ball and make sure that without touching any of the structures inside, you put the balls on the end of the crosses and the middle of the crosses, or in the square. And this gives them the good exercise to use their left hand more precisely without using the right hand. And this is very important while they're chopping, slicing, stitching the corneal transplants, and so forth. So they can continue doing this ball exercise at home without any assistance from you. And this is the simulation of how we teach corneal transplants in junior, for junior doctors. We use orange peel. So peel the orange, essentially, create a flat piece like this, and stick it to a cardboard. Remove the small disc from the peel, and then give them some forceps and instruments, suturing forceps. Give them a bigger suture, for example, 6-0 Vicryl or 6-0 silk or something, which you can see without a microscope, and just use an iPhone, as I showed you before, and ask them to stitch, and send you the pictures of stitching and videos of stitching. And that way you can teach them remotely how to pass on the threads and sutures and so forth. So this way, you don't even need any microscope, or you don't even need any rubber eyes, which are quite expensive nowadays for the trainees. So I'm not going to show you the whole video, but this trainee stitched the whole corneal graft. Now, what if you have all the technology, all the staff, and everything in the hospital, but you don't have patients? In other words, you are in COVID lockdown, you're not allowed to see or operate the patients, and you're still supposed to be at the hospital. Then you can use that time to train your trainees. And that is what we did in our lockdown in Brighton. And this is what we produced at Brighton. Thanks to my co-authors for that. This paper is soon being published very soon in one of the international peer-reviewed journals. I'll show you a brief snippet of what we did. So we had the same exact setup as we did for our cataract surgery. We requested our oculoplastic surgeon and VR surgeon to be the actors here. We went through the regular WHO checks and everything with a dummy model from Philips Studio, which is here on the table. And then we wanted to simulate a PC tear for a trainee. And how do you manage a PC rupture? So we created examples of patients shouting. If somebody was speaking from behind the door, so, oh, doctor, it's painful, or something's happened, the patient's moved, and there's a rupture of the capsule. How are you going to manage that? And then we had cameras set up at different places within the theater, so that when you move further, you will see what happens during the surgery, as well on the lower bottom here. So the surgery is done on a pig's eye, as you can see here. And we showed this to the trainees on how to do it. But before they did this experiment themselves, they were asked to have a go at this model without any learning or teaching from us. And then we showed them the video of how to manage all these things, and then they had to repeat the exercise. And that way we calculated the score difference between how much they have learned by looking at a specifically training purpose video for this model. Now, this video also shows how to hold and fold a 3-piece lens in a posterior capsule rupture cases. So this is what you can do if you have the full hospital staff and no patients in the lockdown period during COVID pandemic. So that's all from me, and I would really sincerely thank Yanis for inviting me. Thank you, Yanis. And
thank you, Mayank.
As we said, TIA is very grateful in providing this, so thank you. This is what we use at UKI CRS in the UK for training juniors, and this works fantastically well. You've got everything here to train a junior. Thank you.
Thank you, Mayank. Mayank is a very high volume. Mayank is a very high volume cataract surgeon as well as a corneal surgeon. He's coming from a family in India with a historic cataract surgeon's family from India. He's one of the most prominent young ophthalmologists in the UK. And from what we're trying to put together here is, as a college, is we try to get the collaboration. Most of us will learn surgery in the UK, of course. So, I mean, the newer generation are going to be a little bit more difficult to get to UK because of the restrictions of the European Union and so on, because of the Brexit. However, these two guys, both Mayank and Hutch, are paramount key players in training younger ophthalmologists. And because in the new era, in the post-COVID era, we will have much less surgical time, not only for us, not only for our patients, let alone for our residents to train, a lot of this basic training should be done at home. The purpose of this session today is how you youngsters, younger ophthalmologists, can have basic training at home with very inexpensive material like Mayank showed you. So Mayank is one of the important key players in the college as well as in the UK SCARIS, another major institutional arm in the UK, and we would like to have close contact and collaboration with both of you to instruct our newer generation Greek ophthalmologists how they bypass the initial level in order to be able to go and do surgery. What I'm trying to say, I'll be in Greek, κανείς δεν θα επιτρέπεται σε λίγο καιρό να κάνει χειρουργείο σε ανθρώπινα μάτια αν δεν έχει περάσει μερικές πίστες με τεχνητά μάτια και με wet lab surgery. What I'm saying is nobody will be allowed in a little while to have live surgery on humans unless he has have a basic level training on artificial eyes. What is your thoughts?
It's an excellent idea, Yanis, and I do appreciate that. That is very much possible. I think college will be very interested in collaborating in that way. The only logistical issue is to set up the centers where we can have similar setup where the setup is attached to a microscope or a camera which can be linked to somebody in the UK, or an online link can be set up. So,
can you say that again a bit more louder? This is very important. So somebody from the UK, we set up something in Greece, okay, and from the go ahead.
So basically, if you have 2 or 3 hospitals within the Greek islands where this setup is set up, attached to a camera, that can be transmitted to anywhere in the world, essentially, then we can Zoom link up or link up on Teams or something and see what's happening while the training is doing the microscope surgery, and then guide them in real time to do the rexus in this and that way, or, for example, do the phaco in this and that way. Ideally, if this is within an operating theater of an hospital, which is not used, it will be good because they can also use a phaco machine and all the stuff. Because establishing a wet lab with a phaco machine might be an expensive option. But if you can, for example, set up a session over a Saturday or Sunday when it's closed, collect few trainees, then certainly we can have some trainers from UK teach them how to do the surgery.
Excellent. So what I'm trying to address to the younger age ophthalmologist of my compatriots is we have a Facebook page of the college. People who would be interested to have this kind of sessions. I mean, we find a way to connect with our British counterparts, and with your help and assistance, we can put forward these issues with our youngsters. What do you think?
And Hatch has got a very nice online system where you can connect the thing, and we can use Hatch's system to link up, and that'll be great.
I encourage you, the youngsters who wants to have a talk with both of them after the session, get some information about the UK, because UK remains the place where you learn surgery. So you have to fulfill the new demands for being able to go to the UK and do surgery. So talk to both Mayang and Hatch, because they are the most appropriate people in the UK now to advise the younger ones. Thank you very much, Mayang. And now it's Hatch Mukherjee. Any ερωτήσεις, παιδιά? Μην διστάζετε, ναι, βγείτε μπροστά, μην διστάζετε. Κύριος Χαρόνης. Κύριε Χαρόνη, πείτε μας για την ελληνική οφθαλμολογική εταιρεία. Και για...
I think we're done. We're done, I think. We're finished.
I think we're done.
Yeah.
Unless there's any questions.
Any questions? Any questions for us?
Oh, I just wanted to congratulate you for your very brilliant ideas to use such cheap materials to do this simulation, because I had in my mind always the expensive simulators which cost over $150,000 US dollars. But
so the ideas came because of that only. We only have 2 or 3 in our region, and they are 95,000 pounds. Which is about 120 euros, 120,000 euros. It's very expensive. Also, in the lockdown, to move the trainees around from one hospital to other was difficult. So that's why we got up this. Now, mind you, this is not the only ideas you can have. You can develop your own ideas. You can use anything you feel like, which gets the feel of a live cataract surgery. So thank you.
Thank you.
I think what I would like to address here is I have talked with Tatseris and some other guys from the college, and I get Yorgos Vartsakis. Is here, Yorgos? Yorgos, where's George Vartsakis? No. Anyway, George is here. I mean, he's a vitreoretinal surgeon from Sweden, along with other younger ophthalmologists. They put together our scientific section of the Greek college. I will connect with both Mayang and Hatch. He's going to be our representative of the Greek college to get information and get the connection how youngsters, Greek youngsters, could be associated with you and get this training. It's exactly what you said, George Haronis. Αυτό ακριβώς που είπες. Είναι inexpensive materials that will help you from home. You don't have to have an expensive simulator. You don't have to go to any place. You can stay home, have a link, hook up with somebody like Mayang or Hatch, and teach you at home. You get all the basic dexterities, and then once you go to the operating room, it's going to be much easier for you.
Yeah. And if you set up 2 or 3 centers, and Yanis, you being the president, you might be the best person to organize that.
We would like to discuss after the session how the details of how we can put that together, because we really want to have an open access to a couple of the one-day surgery units, which practically they are all over Greece, to have this kind of equipment, which is not very expensive. Anyhow, anybody can support that. Yeah. We have our operating room, so be able to connect with you and get the wisdom out of you. Yeah. Thank you very much, Mayang.
Thank you.
Very good.
Thank you.
And now, Hatch Mukherjee. Hatch used to Hatch. I want to say something about Hatch. He spent a year with me in Crete. He's one of the prominent new surgeons in the UK. But what you have to know about Hatch, it has put together one of the most brilliant simulating surgery centers in Colchester, Essex, just outside London. And I would like you to tell us a couple of things about your surgery and your imminent fellowship there, training fellowship. Get the mic. Get the mic.
I'm always very happy to give a shout out to us. We've spent a lot of time and a lot of investment in building kind of 3D surgical training equipment. So we have access to suitable wet lab equipment like you see here, but also 3D visualization with Ingenuity. And we're a small unit, but we're very keen on teaching and education, which is why I reached out to Mayank as a sort of expert in the field as to how can we use these new technologies to deliver training remotely to trainees. Because I remember being a junior trainee, and we used to spend many, many hours in operating theatres looking down the side of a microscope while someone else is doing the surgery. It's a way to learn, but it's not a very efficient way to learn. And I think that we can move that part of surgical training out of the operating theatre into people's homes in their own time with junior instructors, so that when people are in the operating theatre, they're using their training time more effectively. And that's kind of what we've tried to develop with the ICINI program. We also have an international fellowship. At the moment, it's unfunded, so you'd need to seek an appropriate bursary or self-funding, but we're always very happy to welcome applicants. We train in the use of femtosecond cataract surgery, excimer laser therapies, modern cataract, glaucoma, cornea, and vitreoretinal surgery. So we have a fairly comprehensive program coming up, and you'll see some of those fellowships available on our website.
Thank you very much, Hutch. I think we take care of that. And Γιώργος Βαρτσάκης, είναι ο Γιώργος Βαρτσάκης, ο οποίος μας έχει βοηθήσει πάρα πολύ στην επιστημονική σελίδα του κολεγίου μας. Θέλω επίσης να δώσω τα εύσημα στους νέους οφθαλμιάτρους Δημήτρη Καλογερόπουλο, Γιώργο Σίσκο, Μιχάλη Τσάτσο, Γιώργο Σαϊτάκη, Δημήτρη Μπεσίνη, Φώτη Τσόγκα και Αλέξανδρο Καψοκόλλη, οι οποίοι όλοι τους έχουν συνεισφέρει στη σελίδα που έχει δημιουργήσει ο Δήμος ο Κανιούρας στο κολέγιό μας, στο Facebook του κολεγίου μας. Επίσης υπάρχει και ένα site το οποίο θα το κάνουμε ακόμα καλύτερο και πιο διαδραστικό. Θα ήθελα ο Γιώργος ο Βαρτσάκης, ο οποίος είναι ένας πάρα πολύ ανήσυχος και ικανός νέος οφθαλμίατρος, να ασχοληθεί με το Hutch και με το Mayank, για να μπορέσουμε να φέρουμε νέους οφθαλμιάτρους, να τους κάνουμε associate με αυτά τα παιδιά που έχουν εξαιρετική εμπειρία στο να διδάξουν νέους χειρουργούς. What I'm trying to say is Yorgos Vartsakis is going to be the link between Hutch and Mayank in order to put together the Greek College of Ophthalmology with the Royal College of Fellows in the UK. Σας ευχαριστώ για το session.
Ευχαριστούμε πολύ. Ευχαριστούμε, Γιάννη. Ευχαριστούμε, Πρόεδρε. Και θέλουμε να είσαι και ο επόμενος Πρόεδρος για τα επόμενα 3 χρόνια στο Κολέγιο και το όραμά σου να το συνεχίσουν οι νεότεροι. Να σας πω ότι 280 άτομα περάσανε σήμερα από εδώ. Πάνω από 300 έχουν δει μέσω διαδικτύου και βλέπουν ο καθένας ανάλογα με το ενδιαφέρον του το συνέδριό μας. 290 άτομα παρακολουθήσανε φλωρέτινα, τα live surgery, οπότε κάποιοι από αυτούς παρακολουθήσαν τα χειρουργεία, μετά ήρθαν σε εμάς, ξαναπήγαν στα χειρουργεία.
Έχουμε 5 λεπτά να κάνουμε ένα simulation τώρα, surgery όχι. Hutch, can we do a simulation for 5 minutes?
Ναι, αλλά δεν ξέρω αν μπορεί να το δείξει. Θα φαίνεται στην οθόνη αυτό που κάνουν.
Can we do that?
Υπάρχει, 5 λεπτά έχουμε. Ωραία.
We have 5 minutes. Let's do that because this is very essential. Do not... Μην το υποτιμάτε αυτό, γιατί ουσιαστικά...
Γιατί είμαστε πριν το χρόνο, γιατί ξεκινάει 4,5 ώρα το fan club.
5 λεπτά λοιπόν. Hutch and Mayank. I hope you don't have tremor, eh? No, you go. Let's see. Don't expect me to be a volunteer, eh? Έχουμε καθόλου ερωτήσεις? Είναι κάποιος που δεν βλέπω? Έχουμε ερωτήσεις καθόλου? Ο χειρουργικός χρόνος θα ελαττωθεί πάρα πολύ τα επόμενα χρόνια και ουσιαστικά αυτό είναι κάτι πάρα πολύ βασικό, το οποίο το κολέγιο θα προσπαθήσει να το εισάγει στην οτροπία των νέων οφθαλμιάτρων. Ήδη υπάρχουν πολλές δημοσιεύσεις έγκυρα περιοδικά, πως άνθρωποι που παίζουν όλα αυτά τα ηλεκτρονικά παιχνίδια έχουν μεγαλύτερο dexterity, είναι και ambidextrous και dexterous πιο πολύ από το μέσο όρο που δεν παίζει αυτά τα παιχνίδια. Επομένως, όλο αυτό θα είναι πάρα πολύ βασικό τα επόμενα χρόνια. Πάμε. Ναι, αυτό θέλουμε να βλέπουμε. Αυτό είναι ουσιαστικά. Αυτό να γίνει από το σπίτι σας και θα το βλέπει ο άλλος στο Λονδίνο και θα σε διορθώνει από το Λονδίνο τι κάνεις λάθος, που είναι τα χέρια σου κτλ. Δεν είναι ανάγκη να πας σε κανένα μέρος. Κάθεσαι στο σπίτι σου, στην κρεβατοκάμαρά σου και παίζεις με αυτά τα, όπως είπε ο Γιώργος ο Χαρώνης, τα φτηνά υλικά. Και κάποιος σε κάνει supervise από πολύ μακριά. Υπάρχει ένα session, παραδείγματος χάρη, στην Καλιφόρνια, που μπαίνουν κάθε 3 εβδομάδες, μπαίνουν και κάνει χειρουργείο και σε παρακολουθεί κάποιος και σε διορθώνει από την Καλιφόρνια.
So this is the setup which we normally... This way. This is a setup which we normally use, and as you can see, the only drawback of this setup is the magnification. You don't have much control on the magnification. Your magnification is too high, but that's okay for the trainees. Yeah, so even that actually, that's too high. So this is the lowest we can go. Okay, you can be...
Yeah, so the idea is that you'd have somebody training, obviously not Mayank, but and we would provide with either the institution or a pre-packaged sort of equipment for this exercise, and then that person would be connected remotely to a live stream instructor, and that could, with this sort of equipment on loan, that could be a home, but probably the simplest place it could be would be in your kind of operating theatre, in your usual operating theatre. And if you have a video output there that can connect to your laptop, we can give you the sort of bits to do that quite easily. Or even with something like a mobile phone or an iPhone, you can just attach it to the assistant piece of the microscope if you have one. And then that creates the possibility that, across the seas, I would be seeing this sort of picture and be able to communicate with Mayank. And we also have some whiteboarding facility that we don't have here to demonstrate and show what we want to do. So Mayank is just off the screen a little bit, the incision side. If you move it, the whole globe away from you a little bit, I think, towards you a bit. A bit more towards you. A bit more towards you. That's perfect, yeah, I think that's all right there.
So this is what you may encounter, but that's fine.
Maya, if you are nervous, we can help, eh?
Still, that's great. So you can see the keratome incision, and then Mayank is going to use a little bit of viscoelastic. So I would probably ask him to attach the cannula, or use one with the cannula attached, which we have there. Just move it a little bit away again, because it's... no. I don't know which way it's moving it. That's it. Perfect. That's it. Okay, that's great. Just remember when the cannula goes in that it needs to be flat with the iris plane, so it doesn't injure. Is anything coming out? No. Let me try this one.
Cannula's anyway, we've got that. So that's fine.
They've got the idea.
Yeah, we can go to the Vexus. Yeah, that's fine.
Είναι καλύτερο να έχεις κάνει μερικά supervised sessions. Έλα Γιώργο, έλα πάνω, έλα πάνω.
The cannula is a block, but this one.
How much does this eye cost? Γιώργο, take a microphone because this is interactive. We'll have to talk to each other.
So this particular eye, I think about 28, isn't it?
No, well, it depends on the volume, actually. You have to negotiate with Philips Studio. I think we got it for about 40 quid an eye, but when we started buying it, it was about 60 quid an eye, 60 pounds. But now, if you buy in bulk, it might be around 25, 30. But you can, by the way, you can also get these eyes for vitrectomy. You can also get these eyes for just cataract surgery, or you can get aphakic eyes for putting the lenses in if you want to. There's so many models. I don't have any financial interest in these models, but there are 2 or 3 companies manufacturing the same kind of things. This is an expensive setup. The head itself might cost about 400 to 600 pounds, depending on what kind of head you want. We have a real head. This is just a plate head. The real head costs about 600 pounds. But this one will cost about 450. So it is still
Mayank, please go ahead and do some of the manipulations, because I would like you to have a direct feedback from Hutch. So you have to fantasize how would you do it at home, because it's much more different to have supervised surgery, and rather than doing 100 cases, it's better to do 10 supervised than 100 unsupervised, because these people will correct your manipulations, the way you hold the instruments, the way the angulation you enter the eye, and so forth. Therefore, this is a kind of frodisterio.
So, in terms of the sizing, how do you kind of gauge that? So it's difficult, but I think that's a very important part of Capsulorhexis. So right from the beginning, we've started the Rhexis at the right size. And I don't know, Mayank, whether you have any kind of tips for that, but for me, I usually look to be, for a well-dilated pupil, I want to be about halfway between the center and the pupil edge to get the kind of right size of Rhexis.
My inclination is to cover the optic with the Rhexis, so I'll size the Rhexis accordingly. Here, I'm going in the periphery, as you see here. So if I want to, if the trainee is going in the periphery while doing the Rhexis, I'll ask them to pull the Rhexis flap towards the center, like so. So, as you see, my Rhexis tear is going in the periphery, but I'm trying to pull it towards the center so that the curve is maintained and the tear doesn't go in the periphery. You can also see this in white cataracts.
Absolutely. So you can see by that kind of sideways or radial pulling, the Rhexis has come back in, and it's actually beautiful and circular. And that's again pulling towards the center. So that's great. And you can see even with these relatively inexpensive eyes, you can get quite a good simulation of Capsulorhexis.
At the most in this setup, you can do hydrodissection. We don't have a phaco machine here, but as I said,
you can do phaco. Of course, you can do phaco.
You can do a phaco. Yeah, this is phacoable eye, so you can do a phaco. These are basically wax models. So these are wax models, so you can phaco them if you want to. There is a capsule there as well if you want to rupture it. In the college wet lab, we fill these eyes with egg white, the white of the egg, to give a texture of the vitreous humor. And you can use Canalog or triamcinolone to stain it and do a vitrectomy as well after rupturing the capsule. So you can get a feel of the anterior vitrectomy as well if you want to.
You see how trendy it becomes. If you go to LinkedIn, you find a number of new factories which put together these simulated eyes, simulator eyes. One name is Bionico, for example. So you understand why new companies emerge, because there is a new need in the market for training. Okay, so keep that in mind. Γιώργο Χαρόνι, θες να πεις κάτι, πες μας? Η Γιάννη τα ξέρει? Okay. Thank you very much, guys. Thank you for coming.
Thank you.
And we appreciate it.
Thanks for inviting us.